Welcome to our second and last video on diseases of the stomach. Let's begin. For peptic ulcer disease, we'll be discussing the definition, pathophysiology, risk factors, clinical features, complications, diagnosis, and management. Peptic ulcer disease is a disease characterized by the presence of ulcers caused by mucosal damage in two possible locations, the gastric mucosa or the duodenal mucosa. In peptic ulcer disease, there is either impaired mucosal protection against gastric acid or increased gastric acid secretion. This leads to damage to the gastric and duodenal mucosa, respectively. H. pylori infection also plays a major role in peptic ulcer disease, which we discuss on the next slide. Here's a schematic image showing the pathophysiology of H. pylori associated with peptic ulcer disease. H. pylori penetrates the mucus layer of the host's stomach and adheres to the surface of gastric epithelial cells. It then produces ammonia from urea by the urease. The ammonia neutralizes the gastric acid to escape from destruction. It basically creates a favorable environment in which it's able to survive. H. pylori then is able to proliferate and form an infectious focus. The gastric ulcerization is then developed by destruction of mucosa, inflammation, and mucosal cell death. The two most common risk factors for peptic ulcer disease are H. pylori and NSAID use. Recall that H. pylori tends to localize on the antrum, releasing urease and protects itself from the acidic environment of the stomach. On the other hand, the protective role of prostaglandin on the gastric mucosa is inhibited with NSAID use, increasing the risk for ulcerization and erosions to occur. The other risk factors include alcohol and tobacco use. Peptic ulcer disease is asymptomatic in about 70% of patients. However, when symptoms arise, it presents as an intermittent, gnawing, or dull epigastric pain, which is often referred to as dyspepsia. Less specific symptoms include nausea and vomiting. Hematemesis and melena are also common because of the lower and upper GI bleeding that can be caused by the ulcers. Physical examination is commonly unremarkable, but patients may present with epigastric tenderness. This is a table that will help highlight distinguishing features between gastric and duodenal ulcers. Duodenal ulcers are usually located in the first part of the duodenum or the duodenal bulb and are much more likely to be associated with H. pylori infection than gastric ulcers. Between 70 and 90% of duodenal ulcers are caused by an H. pylori infection, which is why it is the most likely diagnosis in a multiple choice question. Patients with duodenal ulcers may have signs of weight gain since eating relieves the pain. This is because food helps offset the intensity of gastric acid before it makes its way to the duodenum. Duodenal ulcers have a low malignant potential and are mostly benign. Gastric ulcers are usually located on the lesser curvature of the stomach and are less associated with H. pylori infection. Eating may worsen the pain of gastric ulcers. This is due to food stimulating more gastric acid release, leading more mucosal irritation and worsening of the symptoms. This could eventually lead to weight loss as patients will avoid eating to not exacerbate their pain. Gastric ulcers are more likely to be malignant than duodenal ulcers and will warrant endoscopy with biopsy to exclude malignancy once diagnosed. A 75-year-old female with a known history of penicillin allergy is diagnosed with H. pylori infection. What is the next best step in treatment? The next best step in treatment would be to initiate quadruple therapy, which includes a tetracycline, bismuth, metronidazole, and a proton pump inhibitor. Triple therapy would be contraindicated in this patient because it consists of amoxicillin, clarithromycin, and a proton pump inhibitor. Since amoxicillin is a penicillin, triple therapy would be contraindicated in this patient. Now let's spend some time talking about the complications of peptic ulcer disease. All patients with peptic ulcer disease are at risk for developing a perforated ulcer. Perforation is more commonly seen in gastric ulcers than in duodenal ulcers. Patients present with symptoms of acute abdomen, of which the classic triad includes abdominal pain, tachycardia, and abdominal rigidity. Patients can also develop acute bleeding of their ulcer. This can present with hematemesis, melena, or hematochezia. If you are suspicious that a patient may have a peptic ulcer, the first step in diagnosis should begin with the least invasive option, testing for H. pylori, which can be done with a urea breath test. However, if the patient does not improve or has red flag symptoms, then you should move on to an endoscopy with biopsy. When this is performed, H. pylori infection or a potential malignancy can be detected. If the patient is acutely ill and perforation is suspected, an upright chest x-ray should be performed and will reveal free air under the diaphragm. It is possible, however, that an X-ray is negative for findings of a perforation. Therefore, if there is high suspicion of perforation with a negative chest X-ray, an abdominal CT with IV contrast should be ordered. With this imaging, small amounts of free air or fluid should be seen. For refractory cases of peptic ulcer disease, testing for serum gastric levels can help rule out gastrinoma. We discuss gastrinomas in more detail in our lecture on Zollinger-Ellison syndrome and gastric cancer, so make sure to check out that one for more information. Here's an endoscopic image showing evidence of duodenal ulcer. Let's take a look at the color of the ulcer on this image. There's a white base and a couple of black spots that indicate a previous bleed. Endoscopy is the definitive diagnostic tool in confirming the diagnosis of peptic ulcer disease. With biopsy, we can also further investigate if an H. pylori infection is present. Now let's take a look at this image of an upright chest x-ray showing subdiaphragmatic free air. Peptic ulcer perforation releases air and gastric contents into the abdomen, which can present with signs of peritonitis, such as abdominal rigidity, guarding, and tenderness. Patients who have a perforation must be managed immediately to prevent shock and infectious complications from gastrointestinal contents being free in the abdominal cavity. Remember that any perforation of the gastric tract can lead to subdiaphragmatic free air, so the presence of this on chest x-ray is not specific for a peptic ulcer perforation. Acute management is considered when perforation or active bleeding is suspected. Patients may present with sudden abdominal pain and signs of systemic inflammatory response. Suspicion of active bleeding also requires immediate fluid resuscitation and intravenous proton pump inhibitors. Urgent endoscopy is the definitive test to confirm active bleeding, and it can help with control of the bleed as well. Hematocrit levels may be collected. However, keep in mind that hematocrit level is a poor indicator of acute blood loss because it takes time for the concentration to normalize and reflect the actual hematocrit levels. Therefore, don't rule out blood loss just because the hematocrit levels are normal, and be sure to consider a patient's vital signs such as their blood pressure and heart rate to better understand their level of hemodynamic stability. Patients with upper GI bleeds may have an elevated BUN creatinine ratio, which can be an indicator of active bleeding. Intestinal breakdown of hemoglobin leads to increased urea production and reabsorption in the proximal convoluted tubule of the kidneys. It is important to note that if hemoglobin levels drop below 7, a packed red blood cell transfusion is necessary. However, if the patient is hemodynamically unstable with a high suspicion of perforation, they should be sent for emergent laparotomy or laparoscopy. The preferred procedure for emergency surgical management of gastric ulcers is a partial gastrectomy to not only remove the ulcer, but also to remove the area in case that ulcer was an area of malignancy. Let's take a look at what a partial gastrectomy looks like. Before I go any further, I'd like to mention this image was contributed by Amboss. Thanks to our partnership with Amboss, I can highlight several important features of Billroth procedure. Here's an image of a partial gastrectomy, which is also called a Billroth 1 procedure. On the left, we see a more transparent region of the stomach, which represents the antrum and the pylorus. In a Billroth 1 procedure, these areas of the stomach are resected. On the right, we see the end result of the procedure. The dotted purple line, which represents the cut end of the duodenum, which is now attached to the dotted green line, which represents the cut end of the stomach. When patients present with perforation of a peptic ulcer, this is just one of the surgical procedures that may be performed emergently. Now that we've covered acute management of a peptic ulcer, let's take a look at the long-term management. The first step in long-term management is lifestyle modifications, including avoiding NSAIDs, alcohol, and smoking. Patients with pain are managed with proton pump inhibitors. As mentioned in previous slides, long-term management with H. pylori infection necessitates triple therapy, such as proton pump inhibitors, amoxicillin, and clarithromycin. Quadruple therapy is required when macrolide resistance and penicillin allergy occur. Proton pump inhibitors, bismuth, metronidazole, and tetracycline are the 4 main drugs with this management. Surgical therapy with parietal cell vagotomy is an option to prevent overproduction of gastric acid in patients who continue to be symptomatic. However, remember from our diagnostic slide earlier that those with continued symptoms from a peptic ulcer or those with red flag signs should have an endoscopy with biopsy or potentially be tested for hypergastronemia secondary to Zollinger-Ellison syndrome. Let's take a look at some practice questions to solidify this information. A 31-year-old homeless female is admitted to the emergency department with severe epigastric pain. Records indicate a recent diagnosis of H. pylori infection for which she never filled her prescription. Examination of the abdomen reveals guarding and rebound tenderness. What is the next best step in diagnosis? This is a case of a patient with known diagnosis of H. pylori infection that was never treated, who is now presenting with severe epigastric pain and exhibits guarding and rebound tenderness on examination of the abdomen. This presentation is concerning for an untreated gastric ulcer that is now perforated. Hence, the next best step in diagnosis would be to order an abdominal X-ray to evaluate for air under the diaphragm. If the results on X-ray is still equivocal, a high suspicion of perforation requires abdominal CT scan with IV contrast. Small amounts of free air fluid may be seen. Once the diagnosis is confirmed, this patient will need prompt surgical intervention. Now let's take a look at our algorithm again. If the patient is having acute symptoms and has symptoms of an acute abdomen such as guarding, abdominal muscle rigidity, or has signs of sepsis, then they likely have a perforated ulcer. These require emergent surgery, stabilization with fluid resuscitation, and intravenous proton pump inhibitors. However, if the symptoms are chronic with no red flag signs, then the patient should undergo non-invasive testing for H. pylori. If this is negative and they continue to have symptoms, then they should undergo an endoscopy with biopsy to further investigate for a cause of their chronic abdominal problems. The patient should also undergo an endoscopy if they have any red flag symptoms such as weight loss or dysphagia, or if they are positive for H. pylori but do not improve after treatment. Malignant cells seen on histology suggest gastric cancer, which calls for abdominal CT scan for staging and metastasis. Surgical resection for these patients is necessary. Patients must be educated about the potential risk of malignancy with peptic ulcer disease. When confirmed on endoscopy, patients with gastric or duodenal peptic ulcers must be advised to stop NSAID use, alcohol, and smoking. For pain management, proton pump inhibitors are preferred. It's also important to realize that many of these conditions are intimately intertwined. For example, a type B chronic gastritis due to H. pylori can lead to peptic ulcer disease, which can predispose a patient to gastric malignancy. Now let's tie this all together with a multiple choice question. A 29-year-old female presents to her primary care provider with 4 months of intermittent abdominal pain. She says it burns right above my belly button when I don't eat for a long time, and it gets better if I eat something. Review of symptoms is positive for nausea and fatigue, but negative for weight loss or bloody stools. The patient drinks 1 or 2 glasses of wine with dinner every night and does not smoke. Blood pressure is 110/75, pulse is 87, temperature is 37.1 degrees Celsius. Physical exam is notable for pale mucous membranes and mild discomfort with deep epigastric palpation. Which of the following is the most appropriate treatment plan for this patient once their most likely diagnosis is confirmed? A. Initiate lansoprazole, bismuth subcitrate, tetracycline, and metronidazole. B. Initiate famotidine and Tums. C. Counsel the patient on alcohol cessation. D. Initiate Tylenol and naproxen. Or E. Refer for selective vagotomy. The correct answer is A. Initiate lansoprazole, bismuth subcitrate, tetracycline, and metronidazole. This patient presents with chronic burning epigastric pain, which is strongly suggestive of peptic ulcer disease. Furthermore, her pain worsens on an empty stomach and gets better if she eats something. This is strongly suggestive of a duodenal peptic ulcer, which is likely slowly bleeding given this patient's pale mucous membranes on physical examination. Recall that peptic ulcers are broadly categorized into gastric ulcers and duodenal ulcers. Note that duodenal ulcers are more common in young patients and that eating relieves the pain of duodenal ulcers. This is in contrast to gastric ulcers, which are more common in patients over 40 years old and become more painful with eating. Lastly, note that between 70 and 90% of duodenal ulcers are caused by an H. pylori infection, which is why it is the most likely diagnosis in the multiple choice question. Since option A describes the quadruple therapy that can be prescribed to treat an H. pylori infection, it is the most appropriate treatment plan for this patient. Option B is incorrect because famotidine and Tums would not treat this patient's underlying H. pylori infection. This course of treatment may be more suitable for patients with simple heartburn. Option C is incorrect because counseling this patient on alcohol cessation is not sufficient to treat her presumed H. pylori infection. That being said, her consumption of 1 or 2 glasses of wine a day does exceed the recommended upper limit for women, and an astute clinician should bring this up with her at some point as well. Option D is incorrect because Tylenol and naproxen won't treat her H. pylori infection, and naproxen may even worsen her peptic ulcer disease. Finally, option E is incorrect because selective vagotomy is too aggressive of a treatment for this patient. The standard triple or quadruple therapy should be attempted first, and selective vagotomy is usually reserved only for refractory cases. This concludes our lecture on gastritis and peptic ulcer disease.